we can't just simply trust all technologies, particularly when they're in that high risk category. We need to make sure that anything we're signposting to is safe and effective and has gone through required checks. And you're probably thinking, well, what are those checks? And I will come on to that. At the moment, from a national perspective, MHRA have advised that at the moment for AI technologies to be certified under, if they are a medical device, they've currently said that they will reduce that to class 1. And what that means is that it's a self-certification. And the reason I've headed this slide with it looks like we're going in the wrong direction is because, of course, we need better, more robust assurance than simply somebody saying that they are safe. And although MHRA have done that with good intent, and they've done it so that we can open up the market of AI actually on the ground and at levels of regions or organisations, that leaves you in a really difficult position of knowing whether you can or cannot trust something. By comparison, in Europe, they've got the European AI Act, and this is a little bit more, well, it's quite significantly more robust than the proposed path with MHRA. And this is about saying you've got to be clear in what your risks are. Now, what we've been doing is we've been working with regulators and commissioners, providers, not just in this country, but globally, to develop a tool that really helps you do that very practically in an operational way. And these are the 6 steps that the AI risk profiler takes technologies through. And these are the things that you might want to think about if you're wanting to use AI in your own locations. And so what we try and do in all of our work is really understand objectively, first of all, what the risk is within a technology, and then understand what mitigations and what evidence has been supplied that could meet and mitigate any risks found. So you first of all need to think about the context in which the technology is going to be used. So is it replacing a clinician? Is it working alongside? Immediately you can see that alongside is less risky than instead of. The second one is, what does the AI actually do? So is it purely speech to text? Is it diagnosing? Is it supporting decision support? Is it taking autonomous action? And then the third thing is, how does it work? Is there, you heard from the previous speakers on the single point of access that there's human oversight. Is there human oversight? What has been used to train the data? Is it integrated into other environments? And a combination of those 3 things really helps you to then understand what the risk is, and understand whether it's very high risk or low risk. And then, of course, you come into what mitigations have been put in place to mitigate against those risks. So what controls are in place? Have there been any validation studies? Is there a human review? And then what you're left with at the end of this process is a traceable gap analysis, and you can really start to work to reduce the risk over time. Hopefully that is useful, but that is the process that we're taking before when we're assessing a technology for use that has AI within it. This doesn't replace things like DTAC and DCB 0129. It's in addition to. And then what we can do once we know what technologies are safe, what technologies are evidence-based, we've assessed that, we can then curate those technologies and work with EBO to deploy those safe technologies directly to patients in a very bespoke way where signposting happens at point of need.